So a very warm welcome to the first webinar of this ARC North Thames Innovation and Implementation Science webinar series. My name is Haritini Stavropoulou and I'm an associate professor in health services research at City University and the co-director of the Center for Healthcare Innovation Research at City. So it gives me great pleasure to be chairing this first webinar on learning from a crisis, how to embed healthcare innovation in challenging times. We have three wonderful presentations by Professor Carl May, Dr. Alexandra Zeman, and Professor Rifat Atoun. Since this is the first webinar of the ARC North Thames Innovation and Implementation Science theme, I thought that it would be good if we give a very broad overview of the host institute. So the ARC North Thames is one of the 15 applied research collaborations that was funded by the National Institute for Health Research across England with the aim of improving the health and social care of patients and public across the country. So it brings together a wide range of stakeholders, including universities, NHS trusts, commissioners, local authorities, the public and charities, and the industry. So the innovation and implementation science theme is one of the 5 key themes that the ARC North Thames has developed, and it does focus on, of course, the implementation of healthcare innovations in healthcare. They will be hosting a number of very interesting webinars in the next few months, and we will talk about them a bit more at the end of the session. So the first webinar is co-hosted with the Center for Healthcare Innovation Research, an interdisciplinary center at City University of London that brings together scholars from both the School of Health Sciences and the Business School at City University. And the main aim of the center is to offer a fresh perspective into the challenges of embedding healthcare innovation in a sustainable way and at scale. I believe that on the chat there will be the websites of both organizations for you to have a look if you wish. So today's webinar focuses on learning from a crisis, and the 3 presentations will focus on how to embed healthcare innovations in challenging times. So I suppose the last year has shown how in periods of crisis, the periods of crisis can bring challenges, but may offer also opportunities for the spread of innovation in healthcare. So the aim of the webinar, we thought, was to draw lessons on implementing and diffusing healthcare innovations in these disruptive periods, and Covid-19, of course, is one of them. So we have 3 wonderful presentations from three speakers, and each presentation will last about 20 minutes. So the first presentation by Professor Carl May, Professor of Medical Sociology at the London School of Hygiene and Tropical Medicine, and theme lead for the ARC North Thames Innovation and Implementation Science, will offer a more theoretical perspective and discuss a model of embedding innovation in challenging times. The second presentation by Dr. Alexandra Zeman, Senior Research Fellow at the Center for Healthcare Innovation Research at City University, will present the results from an empirical work that Alex and her team have done around the implementation of healthcare innovation across England through the academic health sciences networks and during the period of Covid-19. And the third presentation by Professor Rifat Atoun, Professor of Global Health Systems at Harvard University, will offer a more systems perspective into the topic. So, as I said, each presenter will have 20 minutes. There may be an opportunity for, if the speakers finish a bit earlier, to have time for questions following the individual presentations. If not, please hold your questions and put them on the chat, because there will be at least 20 minutes of panel discussion at the end of the 3 presentations. So without any further delays, could I invite Carl to present on the first presentation. I will stop sharing my screen and over to you, Carl.
Thank you very much. Okay, let's see if I can make this work too. Unbelievable. Well, hi everybody, I'm Carl May. As Karatine has just said, I'm a sociologist, and I've spent quite a bit of my career trying to understand really how health professionals implement things. For a long time, I didn't realize that I was doing implementation research. And then suddenly, in the middle of the 2000s, a whole new discipline called implementation science seemed to be invented overnight. And I discovered that that's what I did. Before that, I thought I was just a researcher in science and technology studies. But anyway, what I and my colleagues, many friends, have been doing over the past few years is trying to develop really strong, workable models of implementation processes that people can use to plan and evaluate and sometimes audit and measure implementation processes. So I'm going to be talking about one of those today. One of the extraordinary features of the COVID crisis in the United Kingdom is the rapidity of change that followed it. In a context in which the National Health Service has previously been characterised as a very slow behemoth that struggles to innovate, that struggles to change. In fact, overnight, it completely reconfigured itself, it seems to me, and abandoned many of the things that it held dearest around how it interacted with patients and service users, and replaced most of those interactions with either no interaction or a remotely managed interaction, a digital interaction. And that's been one of the extraordinary achievements of the NHS in Britain over the past 12 months, that shift from in-person interaction to remote and digitized interaction, and the processes of selection and categorization that underpin it. I'm going to talk today a little bit about that, using it as a way of thinking about what do implementation processes look like when they're not embedded in a clinical trial or a large evaluation project. Most of the time when we study implementation, we do it in a completely artificial environment. We say we're going to build an implementation model in a clinical trial, and that's interesting, but it's nothing like a real world implementation process. So let's have a think about where all of this goes. What do I mean by implementation and embedding? Well, I and colleagues have defined implementation as the translation of the strategic intentions of one group of actors into the everyday practices of others. And that involves so much more than technical work. The moment that we talk about translating intentions, we're talking about power and knowledge and how people can make claims about what others must do. And the moment we start thinking about translation into practice, we're thinking about collective action and collaborative work, people doing things together to achieve things. And the hope all the time is that implementation becomes continuing translational action, that everything that we see is about making something happen and then keeping it happening. All of us have been involved in this in one way or another over the past few months. All of us who've found seminars and lectures and meetings and PhD supervisions and contacts with different banks or gas boards or utilities lost to digitally mediated interactions, either by phone or Zoom or email or web-based portals. All of us have been through this. We've been through an extraordinary and rapid change that hasn't just made us work differently, it's enabled us to work in different places. So all of us who work in a digital environment have now had our work re-spatialized as well as reconfigured. Now, embedding all of that is only one possible outcome of an implementation process. There are lots of others, and some of them involve failure, and some of them involve subversion, some of them involve atrophy. Implementation processes don't always work. And so it's interesting to think about why that might be. A start is to ask us, what is being implemented? I kind of think we often in implementation research get lost in the idea that there is some sort of unitary thing that is being implemented. That's almost never the case. When we talk about an intervention in healthcare, we usually mean something very complicated. So ensembles of beliefs and behaviors and practices, objects that are made up of very complex ensembles of material and virtual artifacts, ways of organizing knowledge and practice, processes and procedures, and finally contexts that shape opportunities for performance or systems that promote or constrain their utilization. All kinds of things, but it's really important not necessarily to think of these in this way. Here we've got a map of the NHS, or several maps of the NHS, and one of the things that we can see immediately is how complicated they are. But these are maps, and they kind of specify organizations and practices as places, almost as fixed objects in relation to each other. But what we're actually looking at most of the time when we're looking at implementation processes is contexts that are themselves processes. So over time, these objects operate, and they operate in relation to each other. They change, they move, they shift about. And when we kind of look at what that might mean, the only way that we can deal with it mentally is to simplify it as much as possible. And so here's a very simplified map of what the NHS needed to do to manage to live with the COVID pandemic as it unfolded. And one of the things that strikes me, I developed this map a long time ago to think about another thing, and I showed it at a conference in Ireland, and everyone recoiled in horror. But when we're looking at very complex adaptive systems and very complex processes that are dynamic and emergent, we kind of need to think of all of these different elements of a system interacting with each other and changing themselves over time. Poor Boris Johnson, this time last year, was confronted with something that no British Prime Minister had been confronted with since the 1830s, which was a huge epidemic of a lethal disease that nobody understood. The last comparable enterprise was the Spanish flu epidemic of 1918 to 1922. But before that, the one that had captured the British government's attention was a cholera epidemic in 1832. So these are not normal events. They're hard for governments to respond to. The British government responded with some of the most extraordinary and draconian legislation ever enacted in this country during peacetime. Quite a remarkable restriction on the freedom of ordinary citizens that by and large most people wanted to work with and most people were quite happy with. But within that, two big things happened. First of all, a whole range of our relationships with social institutions were changed. And secondly, organizations themselves were reconfigured. And this happened not simply in healthcare, but in education, in criminal justice and law enforcement, and in defense. Quite remarkable, rapid changes that we can reduce to some very simple categories that conceal the enormous complexity and mask the dynamic emergence of those things as they're operationalized and implemented. I struggle with the sheer scale of the changes that have gone on, and my colleague Anthony Gilbert has charted these in a series of papers on the Royal National, on the implementation of digitally mediated consultations at the Royal National Orthopaedic Hospital in Stanmore. And his work has certainly influenced the way that I've been thinking about what's going on in these very complex processes. So can we have a simple model for understanding innovation and embedding, and in these dynamic process ecologies? And I call them process ecologies because that kind of gets the sense that we have both an environment and a change over time, and that's really really the key to thinking about this. So one way to deal with this is to sort of think about the simplest possible model. So here is the simplest possible model. We have implementation contexts, the kinds of practices in which implementation work needs to be done. We have implementation mechanisms, which is about the collaborative work that people do to make implementation processes happen. And of course, implementation outcomes, how things change when people do implementation work. And these are the kind of basic, this is the basic scaffolding of realist evaluation. One of the things that has always made me a little anxious about realist evaluation is the way in which it's hard to sometimes characterize the sorts of things that we study in those three concepts. We know a great deal about implementation mechanisms, and we believe we know a great deal about implementation outcomes, and we perhaps know less than we need to about implementation contexts. Okay, so what do implementation contexts look like? And we can break them down a bit into to kind of four elements of these processes: strategic intentions, how we create the purpose of an intervention; adaptive execution, which is what we need to do to make things workable; negotiating contexts, which is what we need to do to make things integrated; and organizing logics, which is kind of how when we do this work, it reshapes our understandings of whole systems. The whole protect the NHS slogan that was so important as an element of policy this time last year is a fundamental attempt to reshape people's understandings of the whole system, shifting it from being a public service to a vulnerable resource, and making people think about how they interacted with the service. And I find these very helpful ways of thinking about implementation contexts, because each specifies a particular kind of work that needs to be done. If we look at some very simple, I was tempted to say, here comes the science at this point. If we look at a very simple chart that looks at how process ecologies have changed over time in 4 spheres of digital innovation, what we see is hugely successful conversion from in-person to remote professional patient interaction in almost every context. Absolutely remarkable change. And we can see that that also happens in those areas that have instituted a single point of access for services. So in Cornwall, a key intervention over the past few months has been to realise the potential of a single point of access to all out of hospital services, physiotherapy, OT, those kinds of things, community nursing, heart failure nursing, that kind of stuff. And, you know, again, hugely successful. But we can look at the NHS Track and Trace app and say, well, actually, no, that wasn't workable. And no, it turned out that it couldn't be integrated. And it certainly failed to reframe the way that we think about the logic of the NHS. It never fitted anywhere. The app didn't work. The infrastructure needed to make that app workable and integrated really was never brought into being. But it was, of course, in its own important way, a really important kind of intervention. And it's important to remember that Track and Trace ran alongside probably the best system for actually monitoring the epidemiology and the genetics of COVID anywhere in the world. Absolutely superb. And again, a huge achievement. So we know a fair bit about implementation mechanisms, and I and others have developed normalization process theory as a way of thinking about that. But there are certainly other theoretical approaches that would fit in a model like this, the Consolidated Framework for Implementation Research, or the PARIS model. There are many different ways of analyzing implementation mechanisms. NPT, normalization process theory, has the great advantage of having a relatively simple model. I think the Consolidated Framework for Implementation Research in the end has about 36 different variables. We've tried to avoid that. But what's really important about understanding implementation mechanisms is that we need to focus all the time on the collaborative work and the collective action that motivate and shape implementation processes. So all the time we need to be looking and trying to understand what it is that people do to make implementation happen. And then we can come to the question of, well, what do implementation outcomes look like? When we're thinking about interventions, what is it that we see at the end? I think we probably see 4 things. So we can measure the mobilization of intervention components, and that's something that pretty much all frameworks for analyzing implementation processes can generate. So in normalization process theory, we have the Nomad instrument. And there are other very powerful tools like the re-aim model that help us explore quantitatively the mobilization of intervention components. But once again, it's really important to remember that that interventions are not homogeneous things. They're made up of lots of stuff. So we need to think too about how mobilization of those intervention components, how making something happens, changes the relationships between people. So I have to say, we've seen a lot of changed relationships in healthcare over the past 12 months. It also changes the rules and resources that are brought to bear. These become very important because they offer the structure for action, where relational restructuring offers conventions and interaction strategies for people working and interacting with each other. Normative restructuring changes the rules. It changes the rules of the game. And of course, continuous translational action is what everybody's hoping for. We see things embedded, we see them enacted, we see them normalized. So we can have a look again at our 4 examples here. And absolutely, rapid conversion to remote consultation, intervention mobilization, completely, e-consult, a whole range of other web-based tools, some of which replaced professional patient interaction, some of which enhanced it or added to it. But it turns out there's some suspicion now that all of which added considerably to the workload of health professionals. Normative restructuring, well, the rules of the game were certainly changed. There's no doubt about that. Anybody who's tried to interact with a GP about a routine healthcare problem in England over the past 12 months has certainly experienced the way that the rules of the game have changed and what they can expect has changed. Relational restructuring, absolutely. But the really important and interesting thing is how much of this will be carried on into the world in which, as the COVID pandemic recedes into history, what will we see carried on? I think we're going to see a lot. I think a lot of that is going to be carried on. I think most GP practice now are looking at e-consult as a way of doing the triage work that receptionists used to have delegated to them. NHS track and trace, I feel so sorry for them. They didn't change the rules of the game and they certainly didn't restructure relationships. And really, there is no possibility of continuing translational action. Remote working for radiologists. So radiologists could now start working from home, looking at different images of the interior of the human body, whether those are X-rays or scans or MRIs. And yeah, there is a fair bit of evidence that that's worked out. It will be interesting to see if that carries on. I think probably not. I think probably the radiologists who've been doing this from home will want to return to hospitals. They'll want to return to their professional communities. I think, and we have some evidence of this from studies of teledermatology in the past, that actually sitting assessing scans all day or X-rays is actually a tedious exercise that reduces motivation and leads to burnout. Well, we'll see how things turn out in Cornwall, but I suspect that that's been a very successful intervention in the eyes of the service providers. We don't know what it's been like for service users. Some will have found it very handy, but others may well have found their pathways to care interrupted, and found it difficult to have their choices. So the really important thing to say is that real world innovation and implementation pathways are so messy, they're so adaptive and emergent, they require so much work, and much of that work is invisible. Finding workarounds in digital healthcare is invisible often to the user. It's invisible often to the patient. But the really important thing to say about all of this is that when we're looking at strategic intentions, we're looking at finding a purpose. But when we're looking at embedding those intentions in practice and looking at continuing translational action, we're looking at finding a future. And that future is not necessarily the same as the intervention that we've seen embedded. Things change over time. So just to return to my CMO model, implementation is a process ecology. It's not a linear thing. There are feedback loops. There are complicated relationships between different kinds of actors and contexts and mechanisms. But these can be modeled and they can be understood. And there's a tremendous opportunity here for people who do rapid ethnography and rapid qualitative evaluation to focus on some of these problems. So thank you all very much. I think the fact that I spilled a whole bottle of water all over me during the course of that, that may have meant that I spent slightly longer on this, and I'm sorry if I've overrun, Karatini.
Thank you very much, Carl. I'm sorry about the water, but for the sake of time, I think it's best if we move on to the second presentation, and I'm sure there will be a lot of questions for you at the end as well. So moving on to the second presentation, Dr. Alex Zeman will talk us through her empirical work, and I know that they will fit very nicely with Carl's model, so I'm looking forward to it. Alex, over to you now.
Thank you very much, Haritini, for the introduction, and thanks a lot for having me. And indeed, it links very nicely to what we just heard. Very happy about that connection. So there will be some systems thinking here. There will be some realist at the very end, and I hope it, gives an insight into how spreading of innovations works in practice, and especially when something like COVID-19 or a crisis comes along. So this is based on a study where we explored the spread activity or the approaches that academic health science networks took, and I'll explain in a second what academic health science networks are. So this is before and during COVID. And we really wanted to understand what did they do before, but also then what changed as soon as COVID hit. So we looked into the first 3 months of COVID activity. So academic health science networks are, there are 15 in England, and they're set up at the regional level by the National Health System in England, and each is working across a distinct geography and population, and they're nationally organized as a HSN network. They have the mandate to spread innovations across the NHS, but not to actually do it, but rather to facilitate others to do it. So they are really very much about connecting stakeholders who would do the implementation or the spread of innovations, and build relationships to them, be a networking organization. And they have this intermediary character or position, bringing together health providers, academic organizations, local authority, who are then paying for innovations, or providing a legal framework, and third sector organizations or industry. And so there's really no better way, we thought, of studying spreading innovations and how it's done and how it's enacted than looking into how academic health science networks have done it. And the study that we did that during COVID, was together with 2 local academic health science networks, or HSNs, the one in Wessex and the one in South West. And I think both our partners are on the call as well. And this was commissioned by the HSN Network and NHS England. So they wanted to know, wanted us to explore how have academic health science networks operationalized their spread activity before and during COVID. And we did that by interviewing AHSN staff members and just ask them how did you go about it before COVID hit, on the 2 years prior. And then we organized focus groups to ask them the same or similar staff members again, what was your experience during the first 3 months of COVID? What changed in your way of doing spread? What changed in the context, and to understand that better. And we did an in-depth analysis trying to understand one national spread program in particular and really compare how did HSNs go about spreading one program. And that's called the TCAM Program. And I will use this as an example in today's talk. And it's basically a digital innovation, kind of a software that is facilitating data sharing on medications of patients that are discharged from hospital to community pharmacies and general practitioners. So it's when your medication changed when you were in hospital, then your local pharmacy or pharmacist can support you in managing your medication, and can do that better if they get the information automatically from the hospitals. And that's what this innovation was about. And it was spread by the academic health science networks over 2 years. So what did we find when we asked people how did you go about spreading innovations? And we found those top HSN spread principles that I list here, and they really are the basis of the work that HSNs do. So one of them is their very unique intermediary position of being, they call themselves honest brokers. So really not being on any side or having an own agenda other than helping others to spread innovations. This really helps them to be respected by the different stakeholders, but also being in this networking position and being able to bring all the different stakeholders together. So that was a key point. That relates to the second point, which is really about bringing the different stakeholders together. And it's the key work is really about building relationships and engaging their local stakeholder and supporting them to spread innovations. And what they learned over the period of time that they did spreading innovations over 7-8 years is that you rather follow a systems approach here. So they are responsible for spreading innovations across a local health system with different stakeholders in it. And they really realized over the period of time, it's the best thing to get them all in a room, every stakeholder that is involved. So not only the clinicians, but the IT department of a hospital, but also the local authorities. And in this case, the pharmacies and GP representatives, and really get them into a room around a table early on so they can own the spread process more, and that they found that led more to a sustainability or an embedding or normalization of the innovation rather than following a more separate approach. They really are focusing on serving their local health and care system. So local health and care providers are members of the academic health science network. So that's their focus, and that's what they focus on. So whenever a national innovation like TCAM comes along, they really have to see, okay, what's the need in my local system, and to make the innovation fit. And that really relates well to what Carl was talking about before, how the importance of the local system and how to fit an innovation into it, or read the need and try and find a solution that will actually be a solution for the local system. Evidence plays a huge role and was a huge enabler, we found, or academic health science network staff told us about. And it's on one hand scientific evidence, and if you have it, it's an enabler. If you don't have it, it's probably a barrier. And convincing adopters to say, yeah, I want to implement this innovation goes much easier, smoother when you have scientific evidence. But not only that, we also found that hugely important is to have local evidence as well, or localized evidence. So not only does this innovation work, but does it work for me and here in my hospital? What impact will it have? How can I implement it here? How can I make it work? This kind of local evidence played a huge role, we found. And the last point is really about sustainability and how HSN staff really see this as the ultimate outcome, but really challenging one to reach, because the way the system is set up and the way implementation projects are set up, they run for 2 years or maybe 1 year even. And you do a lot of things, building relationships, trying to convince adopters and help them implement it and test it for a while, and then to keep it on. But by that point, the project is over, and the question if this will really be taken on and be sustained is still a challenge. And it's really hard to find or to identify silver bullet approaches how to achieve that, because the system is so different or difficult to achieve sustainability. Nevertheless, HSN staff told us they would really like to rather go for long-term sustainability from the beginning of the project, have that in mind, over short-term adoption. What we really found as a cross-cutting theme that goes over these principles, or sits behind them or underneath them, is this systems thinking. So they have to spread something in their local system. They really realize the different interacting parts that Carl was talking about, and how this is emerging and dynamic and interrelated. And so the HSNs really need to think system in order to successfully spread innovations. So this is the situation before COVID hit. That's also the starting point. So that's where HSNs were at, the kind of experiences they had, or the kind of how did they do spread? And then want to see how that worked afterwards. I will just give an example how this looks for this example, TCAM. So this is again before COVID hit. And I wanted to use a systems thinking way of describing this. This is a boiled down causal loop diagram, where you can see some feedback loops, and you can see the different interactions between the different components that played a role. In blue on the right-hand side are contextual factors, and on the left-hand side in more red colors are the approaches that HSNs took to respond to context factors, or to make the TCAM innovation work in this particular context. And I'll just talk you through it and talk you through what you can see. So it all starts with it being a national program. So the national outer context really plays a huge role for the TCAM rollout. There's a national team that gives guidance, that gives maybe sometimes you have a mandate, you have to do this now and spread this program at your regional level in your regional system. Then there is another outer context category that is more at the regional level. So here it comes in this regional system focus that the HSNs have. So they need to make see different contexts. They need to make this innovation that comes from the national level and need to make that fit into their local context. And that's really one of the important principles that we saw on the list before. So here's a quote from one of our interviews. So you can't have a blanket approach. As much as you might have a one-size-fits-all project, there are local variances and local barriers that we need to address. And our role is to facilitate the appropriate discussions with the appropriate people to try and come to a win-win for all. That really is the work of HSNs in a nutshell, often. Keep local context in mind and build relationships and negotiate with your local stakeholders and facilitate change. Another context factor that was relevant in the TCAM implementation work was around the characteristics of the innovation itself. So this software, or this digital innovation that also comes with a process change. And here we had a good scientific evidence basis, and that was really HSNs saw that as a good enabler to spread. So adopters would be convinced that and trust the evidence, and therefore rather adopt it than not. And the other thing is it came with, the software was quite flexible. So you could choose the kind of software, you could choose the form of the software, how to implement it. And that really helped make this innovation fit into the local context, in the different local contexts. And this is really about adaptation, and that the HSNs were able to adapt the innovation in a certain way or in a certain frame, but still adopt it enough, and it was flexible enough to enable this implementation at the local level. And then there were the different key approaches on how HSNs responded to these key contextual factors. And one, of course, is around capacity building and dissemination of information. So here is the link between the scientific evidence and what the national guide comes up with, and this is what you can use for your training activities. This is what the kind of information you would give your local adopters in order to convince them to take this on. The other thing is then around this local evidence that I mentioned before, and this is a quote that sits underneath this. So if something's brilliant on the Isle of Wight, somebody in Blackpool will go, well, that's the Isle of Wight. That might not work here. So there's something about the first site up and running. And what this refers to is a very key approach that AHSNs are taking is to have a local demonstrator or pilot sites in their local patch, have one hospital who adopted TCAM and where the other hospitals and pharmacies can go to and see, how is it working there? Is it really producing the kind of impact that I would like to see? And that really then moves on the spread process. So that was a key approach to produce this local evidence that is so important. Relevant here is also to mention the financing strategies that HSNs have at hand, so they can pump prime these pilot projects, and they do, and they often do that, but it comes with a challenge of when we think about sustainability, because then who pays for it afterwards, after the pilot project is over or the initial implementation phase. And relationship building and using networks, we say, is it's a key important approach for AHSNs, and it's closely linked to structural activities. And what they saw spreading TCAM is that they have to have a certain person who is, or a kind of person who is the lead on the spread of TCAM at the AHSNs. And it's not a champion, it's not an implementation practitioner or a project manager, but it needs to be a senior local pharmacist, and they have to be employed to spread this. So it's somebody who has the local respect of the local stakeholders, who speaks the same language, who has an understanding of this pharmaceutical innovation. And then that really was a turnaround point for many HSNs to see that the spread would be taking up. And this quote here represents the challenge the HSNs face with sustainability. And although you can try and build, through this relationship approach, build ownership and hope that it will be taken up, the key driving force for TCAM in the end is back at the national level. And it is that the TCAM program is now embedded in the contractual arrangement. So healthcare providers, pharmacists have to do TCAM and are mandated to do it and are paid for to do it, and won't be paid if they don't do it. So unfortunately, or whatever with the implementation scientists want to think about it, that is unfortunately then, if you have to do it, it probably enables your spread. And that's what we see with TCAM. So that is before COVID-19, and I see the time. So how does this look like during COVID-19? What changes did we see? And as I said before, this underlying system is still there. So the HSNs are at a certain point in time, they do spread in a certain way. And the changes that we saw were really in a priority of context factors, and either additions or adaptations in their spread activity or their spread approaches. So COVID hits, major outer context factor. And what comes out of this is really a shared purpose of all the stakeholders. You have one common enemy or one goal you want to achieve. So everybody is rallying around this. We also see is a need for social distancing and remote working. We see a need for speed or urgency, and relevant for TCAM is that there's a change in focus on care homes suddenly. And it also came with a change in the outer context at the regional level, because suddenly there was a new stakeholder that really enabled rapid decision-making, which was the so-called COVID cells. They will only be in place during the COVID pandemic, so they won't be there afterwards. But in that time, as the crisis hit, it was really helpful to have this quick decision-making new body in the NHS that helped the HSN spread. So HSNs really reacted by first seeing what's there, asking their local system. So they have this local system outreach, asking them, what are your needs? Everything changed now. How can we help? What is it that you need? And for TCAM, they really came up with this okay, we have this change in focus on care homes now. We have the focus on remote working. So pharmacists can't get the data anymore on people that are discharged to care homes. We have TCAM. Why don't we use that, adapt it a bit, roll it out to care homes? And that's what they did. So they had an existing innovation that they could rapidly adjust, implement, and or pilot test, and now in a new setting, and that's what they did. The other thing regarding this remote working arrangement was that there was the need, there was an innovation that fit that need, and it was the main priority was, okay, we need a solution quickly, and we need a solution that helps us do remote working. And TCAM as a digital innovation did exactly that. So it was a very good fit, and that really enabled the spread of this in the new setting of care homes. It also enabled a much quicker relationship building. So HSNs, by having to do remote working themselves, were much quicker and more efficient in building relationships they saw. And that's actually something they would like to keep in the future, they told us. Maybe not at the pace, but remote working was really a game changer for them to do their work more efficiently. The same holds true, of course, for disseminating. If you can have online events, you're probably more efficient and reach a larger audience in a more flexible way. A key barrier we saw here now that was actually a key enabler before COVID hit is the evidence piece. So here we have a new setting and no evidence that TCAM works in care homes. And people were worried about that this could be a challenge and a barrier. But the other thing we saw, and that's coming from the national level or from the outer context, is this mindset change. So people were much more willing to accept a lower level of evidence, or it was much more important to have something in place quickly. However, the HSNs, knowing what they know and having the experience they have, saw this opportunity of actually generating this evidence. So they knew they had to do their local pilots and demonstration sites, and they're now using this and be very careful, even if time's short, to have an evaluation in place and generate this evidence of how does TCAM work in care settings. And this is really the main changes that we saw at this very practical example of TCAM. And we saw this again over 3 months. So it's a very rapid way of getting something up and running and spreading an innovation. And so you can really see this focus of this theme of rapid spread coming out of here. And that's what Carl referred to as well. To summarize our findings or the themes around the changes and the spread principles during COVID-19 really is all around this agile and more rapid approach to spread. And the HSNs went about it by having a head start already because they had this established position in the local system. They were an established stakeholder. So when it came to finding new solutions and innovations to solve a problem, people turned to them and they could go and hit the ground running. They also did that by accelerating existing solutions, so a very pragmatic approach. What's the local need? We have something here that we have already tested somewhere else, so we tweak it a bit and it is a good solution for you, and we try and help you by spreading this innovation. Remote working, very helpful to have a more efficient stakeholder engagement, and as I said, they would like to keep that piece. And this window of opportunity to learn really from this crisis and see what can we keep, what works actually, what can we do more, what can we do quicker, or with what can we do more efficiently, and to keep that maybe, but also maybe not keep the pace because that wasn't very sustainable. And this generation, using this opportunity of generating new evidence of spreading innovations during COVID that you didn't have before. So here's the realist way of saying the same thing in a CMO configuration. And this really is an initial theory of change for spreading innovations during times of crisis. Initial because we really looked at the first 3 months of COVID, and it would be great to check with you and with the audience and the co-speakers how this theory holds up now more than 1 year in, or what changed about it. And maybe we can discuss this space later. So the context, as we said, is mainly COVID-induced changes, different focus on different settings, and focus on one disease or problem, the urgency for change, the pace, the need for remote working and social distancing, and the changes in the governance structure, key context factors, and outcomes that were the HSNs were trying to achieve, or rapid spread outcomes that people were trying to achieve, was speed and efficiency, but at the same time balancing that with still having a quality and rigor of the spread approach. And the sustainability challenge is still one. And mechanisms that we saw, how did HSN enact rapid spread approaches, or how could they do that, really are in changes in the reasoning or the behavior of themselves, but also the stakeholders they worked with. And the key ones here were the mindset change, so rallying around a common purpose, and having a different acceptance or a different level of acceptance for rigor and quality, and also then having this very rapid and agile spread approach, and being very flexible to react to the needs, the changing needs. So this is really the summary. Thank you very much. And I'm sorry for going over a bit. Just to say thank you to our study team, so Sarah Robins, Harry Scarborough, Andrew Sibley, and Sam Tui from the two mentioned HSNs, and open for any questions or leaving them until the end. Thank you.
Thank you very much, Alex. I think we will leave them for the end. Just that gives us time for Rifat to go through his the third presentation for today. Rifat, over to you now.
Okay, excellent. So we've heard two excellent presentations by Carl and Alexandra, and what I'm going to say resonates very much with what they've said. And what I will do is adopt a systems approach and look at the embedding healthcare innovations in health systems from a systems perspective. My work is not at institutional level, but more at systems level. So I'm interested in adoption and diffusion of innovations ranging from simpler innovations to very complex innovations, such as health system reforms in health systems and their scale up, but also looking at the impact. So analyzing the diffusion patterns, the processes, and the factors influencing this, and then what outcomes. And we use mixed methods approaches to examine these. And I've done this over the last 30 years in a wide variety of settings in about 30 different countries. So I'll share some of these with you. So let's have a look at COVID-19 and health system responses. Well, as of today, around 140 million cases, reported cases, and around 3 million deaths. Again, these are reported. Obviously, the real figures are much worse than what these are. And the World Health Organization yesterday announced that the third wave was accelerating in many countries. So as a health systems person, if I were to rate health system performance, I know Carl has been very generous to the national health system, but I would rate many of the health systems' performance as being inadequate, being ineffective, fairly inefficient, and highly inequitable. I'll come to that in referring to a study we've published today. And why am I saying this? Is this a harsh analysis? Actually, no. For years, G7, G20, and many other countries have been discussing and doing simulations for a pandemic. We knew that a pandemic was coming. In fact, in a paper I wrote with Richard Coker and Martin McKee from the London School of Hygiene in 2008, our final paragraph in the book we wrote on non-communicable disease in health systems was that, communicable disease in health systems was that we would expect a pandemic, either a flu pandemic or something like a SARS pandemic, but we were not sure about the timing, but it was soon. So we were expecting it, and many countries went into this having undergone self-assessments through international health regulations, and many ranked themselves as being prepared. But when the day came, unfortunately, systems were not able to respond. Is that surprising? Actually, no. If we look at, again, looking at uptake of innovations and their impact on health systems, this is a study we published in PLS Medicine in 2019, at the end of 2019, looking at diabetes, management of diabetes in 29 low and middle income countries. This is using national representative survey data, representing about 700,000 individuals with biomarkers. And in these countries, of every 100 cases of diabetes, only 64% are detected, 48% are diagnosed, just 45% are treated, even though treatment is available and accessible, and just 30% achieve control. We replicated this looking at management of hypertension across 44 low-income countries. It's a paper published in The Lancet in 2019, representing about 1.1 million individual level data, again, national representative with biomarkers. And then it's a breakdown in 4 sort of aggregated world regions. In Latin America, many people have their blood pressure measured, but few are diagnosed, around 60%, but just 20% achieve control. In Middle East and Central Asia, it's about 15%. South and East Asia, this falls to 10%, and in Sub-Saharan Africa, around 5 to 7.5%, with very few people actually diagnosed, with most of the cases missed. So systems were struggling, and we knew that going into the COVID-19 pandemic. And even when the technologies are available, they're not taken up and they don't diffuse at scale at systems level. Much of the research tends to focus on institutional level, but at systems level, many of these innovations are not taken up at a level, at a scale that's going to have population level impact. But the question is why? Well, I think one of the big reasons, and I think Carl articulated this very elegantly, and Alexandra presented a sort of systems perspective, is because we think of innovations in a very linear way. And we think about pushing technologies and solutions into systems without really understanding the context and really not understanding the health system and health system functioning, health system performance, health system characteristics, the institutional setup, sort of the norms, the rules of the game, the power structures, and also not really understanding what the innovation is designed to do. Is it addressing the problem? How is the problem perceived by the adoption system and by the actors in the health system or in the broad context? Is there alignment of the problem with the innovation and the adoption system? And by adoption system, I mean individuals, beneficiaries, such as end users, such as patients, for example, or citizens, managers, teams, or even institutions, organizational institutions. And are these aligned? And is the innovation, what are the characteristics of the innovation? Is it a simple innovation? Is it a complex innovation? Is the innovation introduced over a long period of time? What are the processes of introducing it? So we need to have a systems framework and think of the system as a complex adaptive system with all these components changing over time and changing according to the evolution of the problem and the acceptance of the innovation and scale up. So we're dealing with a highly dynamic context, highly dynamic health system, and highly dynamic environment for the problem, for the innovation and the adoption system. So in order to understand better the factors influencing adoption and diffusion of innovations, I've synthesized actually in this paper, in one or two other papers, some of the key considerations that enabled adoption and diffusion of innovations. And in a summary, in terms of the problem, the narrative is very important. The necessity and the urgency of the problem. That was evident, for example, with the HIV epidemic, with many countries saw this as a major problem, not for just for their countries, but for the global well-being and security. As a result, many of the countries were able to introduce rapid solutions. Again, innovation characteristics are important. especially alignment of the innovation with the perceived problem or the problems, and the legitimacy of the innovation, who's designing and introducing the innovation. And by legitimacy, I mean cognitive, normative, and technical legitimacy. And innovation complexity is important. Simple versus more complex innovations, and the extent to which the innovation can be replicated, can be scaled up, and what the capacity is in the system to enable the innovation to be scaled up in a feasible manner. Adoption system is important. Again, these range from role identity of the actors in the adoption system, the extent of collaboration, which Carl mentioned, extent of competition between and within individuals, teams, and entities, and the incentives, both incentives to generate innovations, but also incentives to pull incentives to adopt innovations. The institutional setting is critically important. And I love the slide Carl showed regarding the NHS. You know, very complicated, multiple legal frameworks, norms, power relations, all of these influence the way an innovation is generated, implemented, and scaled up. Again, health system characteristics are important. The capacity of the system, organizational design, performance, extent of integration between different functions, which is an important consideration for health system resilience, and sustainability of these characteristics when a problem emerges and when a problem is sustained. And finally, the broad context is critically important. The receptivity of context to change, whether an opportunity or a window of opportunity exists, whether there's desirability for an innovation, and the contextual characteristics such as inequalities, distribution of socioeconomic determinants, as well as having senior champions who are going to identify the problem as a problem, but also champion the innovation and provide leadership to the adoption system as well as the system as a whole. So all of these factors need to be taken into account when an innovation is being introduced, but actively analyzed to understand what needs to change to enable the introduction and rapid scale-up of an innovation. And we've used this framework to explore introduction of innovations for managing single conditions, for example, looking at tuberculosis control in multiple settings. We also, with Yanis Kiratsis, in this paper that was published in the Academic Management Journal, we explored institutional logic within the adoption system and the broad context and the professional identity in the adoption system, and how this influenced the introduction of complex primary healthcare reforms in a number of post-Soviet countries with varied level of adoption and diffusion. And again, here it was less about the understanding of the problem or recognition of the importance of innovation or the capacity of the health system. It was more about institutional logic and role identity that really influence innovation, adoption, and diffusion. We've also looked at, across 10 countries, how universal health coverage, again, another fairly complex innovation, was introduced and scaled up in the context of Latin America. Here we analyze contextual factors that influence adoption. And here social movements were critically important, especially in countries such as Brazil and a few others, which transitioned from dictatorships to democracy, and universal health coverage was part of this social movement to realize rights and to empower citizens. And we've also looked at all of these factors in simultaneously looking at the introduction of health system reforms. This is the paper, a big study published in the Lancet in the context of Turkey. Here we looked at all of these factors and did a fairly detailed analysis of contextual factors, system factors, as well as factors relating to institutional setting and adoption system that influenced the rapid adoption and diffusion of this complex innovation. And more recently, we've looked at the diffusion of family health model in Brazil. Again, looking at using data from the DataSUS, the health system data set. We looked at diffusion of the family health model from its inception in 1998 through the country up to 2012, where the most comprehensive data sets were available. And then we looked at factors associated with program uptake and coverage of expansion. And here, many of the factors that we laid out in the framework are quite evident, and we're able to quantify these using a sort of econometric analyses. And then we're able to relate this to outcomes. What happens when diffusions are adopted and when they diffuse? What outcomes do they have? And we were able to measure reductions in amenable mortality, both in adults and children, associated with primary care expansion. And interestingly, we found in this paper that the importance of the context and the importance of strong health governance and leadership, which where all things being equal, strong governance was associated with 48-fold increase in outcomes compared to settings where governance was actually weak. But even a country such as Brazil that has done quite well in the context of external shocks such as COVID-19 has performed very poorly. And Brazil is one of the worst performing countries now in the world, even though it has a fairly extensive family health service coverage, strategy coverage, as well as universal health coverage. And actually in a paper published today in the Lancet Global Health, we analyze quantitatively factors influencing the response of the country and the adoption of innovations or interventions, such as new policies to combat COVID-19. And we find here that socioeconomic inequalities and the extent of socioeconomic vulnerability within different districts and states is an important determinant on the preparedness of the system and the response. And we're able to quantitatively show the extent to which these vulnerabilities influence the response, but also outcomes in terms of number of cases and number of deaths. So why do we have this poor performance? Well, looking at the context, if we are to take a highly reductionist approach and try and come up with some lessons, why do we have these challenges in relation to poor adoption and diffusion of innovations, even when we know that innovations are desirable and they will address a problem? Well, one major challenge is that we have unreceptive context. There's often a policy misalignment, whereas industrial policies tend to push and encourage innovation. And NIHR is a very good example of this, as well as many other countries. On the whole, health policies are designed to constrain innovation. So it's actually very difficult to get innovations into practice. Whereas economic policies do not consider health systems' contribution to the beyond health, to society and the economies as a whole, and they don't really create the right incentives to encourage rapid uptake of innovations. So contextual issues are critically important in generating a receptive context for change. The second innovation challenge is the health system itself. If we look at where innovation is happening, and in this op-ed in Financial Times, I noted that scientific developments have spurred unprecedented delivery of innovations relating to new medicines, diagnostics, medical devices, but innovation in delivery side that Alexandra and Carl mentioned, sort of the organizational changes and process changes and new solutions, that has really faltered. And if we look at delivery of innovations, there's a renaissance in science and innovation. But this is happening in the part of the health system that accounts for 20% of the total health expenditure. Whereas innovation in delivery side, new organizational forms, new work practices, new integrated solutions, so on and so forth, there is much less innovation. And this component of the health system accounts for 80% of total health expenditure. So there's asymmetry in where the innovation is needed and where innovation is taking place, and also how the funds are spent. And when I'm saying there is little innovation, I'm being generous. This is a picture of Hotel Dieu de Paris that was established in the 7th century as a hospital, 651 to be exact. Is still functioning as a hospital. So when I say health systems are slow to change, this is one example. 13 centuries later, it's still functioning as a hospital. Yeah, so we are captured by broken systems, and we're really building on these and adding on to them as opposed to changing the system as a whole. And finally, in relation to innovation, there's undue focus on technical innovation, but less emphasis and encouragement and incentives for more higher complexity innovations, similar to the ones that Alex and Carl talked about and I mentioned, that involve multiple actors over multiple levels with multiple use over time. So what do we need to do? To develop agile and resilient systems that will adopt and diffuse innovations. Again, use the framework to analyze what's happening and make the right changes, but create push and pull incentives and enablers and bring together universities, industry, as well as the health system as a whole to jointly address the innovation issue together, not in silos. So thank you very much for your attention.
Thank you very much, Rifat. Not only because you offered the more systems approach to the topic, but also a more international perspective, which was also very interesting. Brilliant. Now we have about 10 minutes for discussions and any questions that you may have for either Carl, Alex, or Rifat. Please raise your hand, or you can still post your questions on the chat. I will keep monitoring the chat, but that gives me the privilege, since I'm chairing this session, to ask the question that I wanted to ask all three of you, in fact. So I think the reason we put this together is to see different perspectives from the NHS, from theory and practice, from different backgrounds. But ultimately, the main aim of this was to see what are the key lessons that we've learned during this past year that could be used for the future. It's not the first, it's not going to be the last crisis, and innovation is not only about dealing with crisis. So I guess the question I had was to try to hear all three of you or your views on what is the main lesson you think that the last year has offered to health services innovation. I know that, and I like your point, Rifat, about how we invest too much on technological innovation. Is much more than that. So if I was to ask you, what is the main lesson that we could learn from this past 1 year, what would that be? So I'll start with the order that you gave a presentation. So Carl?
I think that my answer to that is something like this, which is that in the first few months of COVID in the UK, there was a very clear link between policy and delivery in healthcare. And that made it easy, I think, or easier for different healthcare providers, whether that's individuals or groups or organizations, to make the leap to remote consultation. In the last third of the COVID, I mean, I'm presuming that it's all about to finish in some way, I don't know. That that very clear link has been lost, I think. And that has made it difficult to sustain some of the innovations that we've seen. So I think that the clarity of the link between policy, organizational delivery, and socio-technical change at the level of patient care, I think is the really key thing.
Great, thanks, Carl. Alex, your thoughts?
I think the main thing is not to lose out of sight that we can learn a lot from this and not to not learn anything from it. So I think there's a lot to learn in terms of how to do spread or implementation more rapidly or more effective, and just take that leap of what we, mainly related to remote working as well, and just try and keep some things that worked well and that we now tried out and that worked well, and keep this more agile or rapid way of working, but don't lose out of sight that there is still rigor necessary, or not to keep out of sight that sustainability is still the main aim. So many of the enabling factors will disappear again after the pandemic. So how can we keep what we want to keep within, again, changing context?
Thank you. And Rifat?
Yeah, no, there are obviously many factors as we've all discussed and presented, but for me, the most critical important lesson is that we have to take a systems view of health systems. We have sort of very fragmented approach to policymaking, very fragmented approach to delivery, and as a result, parts of the system function, but the system as a whole in many settings did not perform as well as it could. So very few reached their frontier in terms of their effectiveness and efficiency. I mean, if you look at test and trace, there was no shortage of funding or the technology, but when it came to rolling out, it was not possible to do so. And in the case of NHS really struggled to roll out the system. So really understanding the factors within the system that need to change. And I think Alex's point regarding agility is critically important. So rapid analysis, rapid response, because the context is changing naturally as a result of this shock. So this is critically important to have the right kind of intelligence at hand to change in a rapid way.
Brilliant, thank you. Yeah, are there any questions from our participants? But I can see that, Octavia, you have your hand up and you would like to ask a question, please.
Sorry, I just had one quick question. I was really interested at the idea that the role that evidence played in innovation has changed. I thought that was fascinating. I'd like to hear a bit more about that. And also, because I've seen that in practice, and I've also seen how now that people are maybe trying to roll things back, that suddenly all those checks and balances have started up again and everything is slowing down again in practice. And suddenly everything has to be evidenced again, even though nothing needed to be evidenced before. And I think it seems to me that that's a real barrier to sustaining innovation, even if innovations that have worked. There's this amazing, need to go back to how we did things, regardless of that they weren't evidence-based to begin with. And I'm sort of interested in that, in the role that evidence plays in all this.
Thanks, Octavia. I guess you are referring to Alex's presentation around how evidence changed. So I'll ask Alex to answer this, and maybe Carl and Rifat can give their thoughts.
I think you summarized what we encountered exactly, and this is really this interplay of okay, that might not play a role on short term, and we can look over that we don't have the evidence and we just need something quickly in place, and therefore we just do it, and it feels like the right thing to do, so we go about it. But HSN's really realizing then that this won't work like that in a year's time, or if we want to sustain something, we really need this evidence, so that they knowing that from their past work, that they needed to have this evaluation in place of doing evaluation while they were implementing something new during COVID. Really providing this evidence was really a key thing that they realized, and I think will help then in the end to sustain some of these innovations. But evidence, yeah, we really saw that how important this is, and how important also this role of pilots is, or demonstration, small projects where you demonstrate something locally. Does it work? What impact will it have here? How do I make it work here? This is really key. However, if you run too many of them, then you lose also a lot of time. So if you run a pilot again and again and again, and it always takes a year to do, then you are doing what you don't really want to do. You are widening the implementation gap, or the delay it takes, or the time it takes you wanted to implement it. So there's a balance to be struck between how many pilots you need to do or want to do, or what methodology to provide this evidence that is
or how you pull
needed.
together pilots from lots of different places, when none of them reach that standard of serious evidence, and they're often not published because they're pilots.
Yeah.
So it's really, I'd be interested to know what everyone else thinks.
Brilliant. A quick thought from Rifat. And
yes, I think evidence is important, but evidence is contested, and in a rapidly changing context, there will be a delay between the shocks to the system and the evidence generation. So one has to have appropriate analytic systems in place to learn with what's happening, and ensure that the innovations that are introduced have not just technical legitimacy, i.e. grounded in evidence, but also normative and cognitive legitimacy are among the actors. That's really critically important. Evidence in itself is desirable but not sufficient for adoption and diffusion of innovations, as we have seen actually in so many countries that have evidence-based systems.
Thank you. And one last thought from Carl.
I'm with Rifat on this, but evidence is often irrelevant. Evidence is often generated in a completely different context to that which it's applied. And if we look at some of the big changes in COVID in the UK, there was really no evidence about how to rapidly convert face-to-face general practice consultations to remote and digitally mediated consultations. And what evidence there was about very, very unproblematic things in practice. It certainly wasn't about talking to people about whether they had a suspicious lump or not. So there's a lot of evidence produces often a big cloud of stuff, and you have to really search in it to find material that is useful to the problem at hand when there is a crisis.
So does that change the value of evidence?
Mm.
Have we learned something?
Evidence is only useful if it's useful.
Yes.
I know that sounds tautologist, but it's true. Evidence is valuable in different ways, and the value of evidence is something that's constructed in context.
Yeah, and in dynamic settings, evidence, because everything is new and changing dynamically, evidence will be contested. So it's very important to recognize that.
Thank you very much. Now that I need to take some water before I am able to say a huge thank you to all three participants. Thanks, Octavia, for your comment. I'm sure that we could have a long discussion around this last point, but I'm afraid we are now running out of time. Just before I close, and thanks again to all three participants, but also the organizers who were behind all this. I will share my screen just to show one last time that this was just the first of a series of webinars that are coming up. So please check the website for the coming ones, and keep in touch, because I think there will be some very interesting discussions coming up in the next few months from the ARC North Thames seminar series. So thanks once again, and see you very soon, hopefully in May, for soft power in the clinic.